Welcome, everyone. These pictures up here reflect something that probably everybody in this room has experienced in the last 2 years. But what I want you to think about is how that experience might have been for learners like a resident or a medical student who had less control over their number of shifts, their hours, their finances, and probably didn't have the support systems that you have now as an attending. I'm Breanne Jacobs from George Washington University.
And I'm Rita Manfredi from George Washington University, Washington, D.C. Where are you guys from? Where are you from? Illinois. Where are you from? And that distinguished gentleman back there, where are you from?
I'm from George Washington University as well.
Wonderful. It's great to have you. So this talk is about early recognition and providing opportunities for mentorship to learners to help them navigate moral dilemmas, and it's going to help them promote resilience and wellness in the training programs.
So we have no disclosures, and let's start with some cases. So Veronica is a PGY3 emergency medicine resident in a very busy tertiary care academic urban emergency department where residents, APPs, and others are supervised by an attending physician. They get a call from ENS overhead that they have an elderly male who has a facial droop, but out there on the field he had seizure activity. EMS had to give him midazolam. His blood sugar was 129, and vital signs were found to be stable. So he came to the ED. Code stroke was called. Neurology saw the patient, gave the patient NIH stroke scale score of 13, but then found out that he'd had a history of Xarelto and was also on and had a seizure en route. So they said, nope, he's not a candidate for TPA. So they sent him to the CAT scanner after he was intubated. During this time, our protagonist, Veronica, was going through the patient's belongings and looking for the emergency contact card. And when she found it, she was notifying the next of kin, and it was a neighbor who said, yeah, this gentleman has a living will, and he's DNR. And he had been really, really affected by his wife, who had a prolonged stay in the ICU. He had a lot of PTSD after that. So he made himself DNR. So, resident says to the attending, God, we got to extubate this guy. He's DNR. The friend's bringing in the paperwork now. But, of course, it was change of shift. And the attending says, nope, damage is done. Get the patient admitted, get him to get his LP, and get the MRI, and we're done. Well, Veronica leaves the shift feeling defeated, discouraged, morally conflicted, and she blames herself for not protecting her patient more and fulfilling his clearly documented wishes. So I want you to pause just for a second. Think about this case. What would you have done? This case might elicit strong emotions within you, and so what we're going to do is we're going to present a second case first before we start talking about that. The second case involves Derek. Derek's a PGY2. He's on the SICU rotation, and he has a surgical oncology patient coming in who has esophageal cancer with an upper GI bleed. Patient stage 4 esophageal cancer, and earlier in the day he'd been thinking about maybe moving to comfort care. But then he had a discussion with his spouse, with the oncologic surgeon, and the oncologic surgeon said, yeah, I don't think you're ready to die yet. So they moved forward with curative treatment. In the ED, he was transferred up to the SICU, having a massive transfusion protocol. And so Derek called the SICU fellow to say, hey, what are we doing about his care tonight? And the fellow says, give him whatever it takes to keep him alive until the attending returns in the morning, and call me if you get stuck. So Derek, in the meantime, is called by the nurse to speak with the family over the phone, who are very distraught with his care. They say, he never would have wanted it this way. He was thinking about hospice. He wanted to be with his family, but they went through with what the surgeon told them because he had been taking care of the patient since the beginning. So Eric feels distressed. Derek, excuse me. And he's between a rock and a hard place. He feels compelled to act in the interest of the patient, maybe discontinue some of the really significant artificial life support that's going on, and maybe to call palliative. But at the same time, he feels he has this duty to carry out what his attending has told him to do. So, and he knows the attending cared for him since he was first started his disease.
So these cases talk about moral distress, which is a psychological reaction when one knows the ethically right way or correct way to act in a situation, but for whatever reason, or many, which there might be many, they feel powerless to respond. A lot of the research on moral distress comes from the military. In particular, in the 1990s, there was a clinical psychologist named Jonathan Shea who looked at the moral distress of combat soldiers. And he looked specifically into PTSD that the soldiers experienced, not only for the things they saw and did while they were in battle, but the things that they weren't able to do. Medicine is similar to the military in that we have a hierarchy structure where oftentimes, we place orders on patients. We give orders to junior physicians to initiate a plan of care. And residents in particular are at risk of moral distress because they, like soldiers, are usually the ones implementing the plan of care, which they may or may not have had a lot of say in the creation of. So moral distress, moral injury, follows a continuum that leads to burnout. The pandemic exacerbated the continuum. 1 in 5 American healthcare workers has left the profession after the pandemic. And COVID amplified our moral distress. In particular, we've had to deal with things like rationing of medical care, healthcare providers trying to focus on the prioritize community needs over individual needs when dealing with rationing of care. And this has been particularly difficult on our learners. When learners feel powerless to act in an ethical situation, research has shown it leads to frustration, anxiety, guilt, that decreases workplace satisfaction, absenteeism, increased medical errors, and then eventually burnout. So how do these moral distress situations arise? Essentially, we found that there's gap areas, these are areas of basically the clinician's knowledge of the patient's wishes that differ between which clinician's taking care of the patient. I'm going to go through each of these specific areas in the next couple of slides. But basically what you have are 2 providers taking care of a patient, and they're not on the same wavelength, or they see things differently. And that is what leads to these moral distress scenarios. So first area we'll talk about is knowledge gaps. Now this is the classic case for the 2 examples we provided in the beginning. You have this attending who's very knowledgeable about the disease process, probably knowledgeable about the patient in some scenarios, and then you have the learner who's still in the process of learning about the disease process, and both might have a different idea of what's the best thing for the patient. This could also be knowledge gaps where you have a specialist differing in opinion from a primary care doctor or an ER doctor. The next area where there can be 2 different wavelengths or ideas of care is where you have ideological gaps. Now we know that both Derek and the surgeon were trying to look out for the patient, but maybe the surgeon's plan for the patient or his ethical values were curing the patient from cancer, keeping him alive no matter what. Whereas maybe Derek's ethical principles were trying to support the family, following with what the patient's sort of wishes were for being able to be back home in his last couple of days and not going on an ICU trajectory, which might have led to a SAR, a trach, and PEG. Again, both people are looking out for the patient. They just ideologically have different perspectives about the way to move forward. And then you have the patient wishes or care information gaps. This was like the case we had of Veronica. So a patient might have sat down with their family members and clearly explained that they do want to be a DNR, DNI, they don't want to ever be in an ICU, but that information may not be able to be accessed by an emergency physician who's seen the patient for the first time. And then you can have longitudinal care gaps. This is where you have a primary care doctor who knows the family, who sat down with them, or maybe the doctor who's the head of the nursing home where the patient's been for a number of years. And they have a clear understanding of what the patient would and would not want to happen if they were to get sicker, versus us, the ER doctor who's met them for the first time, and we have a default where we just go to full code for everybody. So the topic of this is, what can attendings do to support particularly their learners in the emergency department? Well, early recognition and mentorship can make a huge difference in preventing moral distress in residents. One of the first things that you can do is promote discussion of ethical questions and encourage residents to voice their perspective. At Weill Cornell Medical College, for the internal medicine residents, they do 20-minute didactic sessions where the residents are separated into small groups of 10 people, and it's moderated by an ethics fellow. They're able to share their different cases they've gone through while being on ICU rotations and find ways that other people have learned to cope with difficult ethical circumstances. Another thing you can do is increase ethics training in your emergency medicine didactics. When I was a resident at Emory, we had what was called a cross-residency ethics program where they took residents from other specialties and we all sat together with medical bioethicists, members of hospital ethics committees, palliative care team members, and we were given different cases to go over and learn about how different situations one could respond, and you often learn there's no right answer. You're just trying to do what's in line best with the patient's and the family's goals. And then finally, one of the most important things we can always do is increase communication with the residents. Think how different that Veronica case might have been if the attending, rather than hurriedly say, let's change the shift, just admit him to ICU, actually sat down with her after the shift and said, look, I know that the patient's DNR, DNI, and we should extubate and follow his wishes, but it wasn't the right scenario in a packed emergency department. It's chaotic. The better scenario would be up in the ICU where the palliative care team can do it and maybe a family member could be present. If perhaps the attending had just explained that to her, it might have prevented Veronica from experiencing moral distress. So we leave you with this.
So every physician, every learner has a story, a background, their own perspectives, and they have to be recognized. And that goes for Veronica and Derek and all their attendings too. So there's this gentleman by the name of Dr. Peter Black, who's emeritus up at Mass General now, and he taught residents about moral distress. And he used the poem Desiderata, which was actually written in 1927 and became very, if you were in college, some of us in this room were in college around that time, a couple decades ago, it was very, very, it was all around everybody's posters. But it's really a very simple, positive credo for life, and it means things that are desired. So without surrender, be on good terms with all persons. Speak your truth quietly and clearly, and listen to others, even the dull and ignorant. They too have their story. So we want to thank you.
Thank you. And we want to offer you the opportunity to share with us your thoughts if you were the attending taking care of Veronica, or if you're a resident in the room and you've had a case like that. What experiences have you had?
Yeah.
What are your thoughts on this?
What do you think about that, the Veronica case? It's more than frustrating. It's moral distress. That's what you've got. That's for sure. I think we all do. But just one question I have. Is there anyone you can talk to? Are there any attendings in your department that you can go to? That's wonderful.
Yeah, and then not like central area around everyone else,
Yeah.
just take a walk. And that's really helpful. I think more, I wish more of our attendings were to walk, take a lap for 10
Take a
minutes.
lap.
Other ones make you go up the stairs with them, which is not, but
Yeah.
it still gets you out and,
Can talk about it. So there is somebody there. Are there any attendings in the office? I don't know. I do know Dr. Boniface is attending. I don't know if the person behind. What thoughts do you guys have?
I was wondering, like, when you do the walk and talk, does the resident initiate this, or does the attending, or both?
it's a
Depending on the case?
I seek it out more
Yeah.
just because of my own personal nature, because I don't want to go home with this, but,
Oh, good for you.
other attendings, you have to push for it, but we have one attending who's been doing this for years, and so he's really good at, even with procedures, if we're not doing the procedure, we're really hard on ourselves, and tell him, it's like, all right, we're taking a walk, let's go.
That's great.
So he's really good
My
at
pen.
that. Oh, sorry.
We got to write this down. We're going to steal your idea.
Do you have palliative care attendings that you've met in your ICU rotations, or any that you know you could talk to, email to? We have a palliative care attending. I did not do ICU at our hospital. I did it at the VA, which is no longer a stipend to ICU anymore. So I don't have the same resources, but I know my residents have the palliative care attendings sell to them. But we don't really call them all the time from the department, and we now have a chaplain that'll come too to discuss with the families, which is good.
Yeah, the problem is the moral distress is on us, and we're the ones that need to be taken care of. I agree. It looked like, were you guys going to say something? I need my glasses.
No, so I'm a faculty at Yale, and through like more so of a passion project, I actually do book health research, but through a passion project came to becoming my wellness officer. Not expert in wellness, I'm just passionate about it, and much of it I can just put I coming to me during COVID basically 2 years ago. Anyway, I came to not steal ideas, but learn about others' good ideas as well. On a very important topic, because some of us wrote this book, attendings and residents are. So, yes, I guess I was just curious, what, besides the ethics training, which I think is a really excellent idea, like what other projects or programs, I was just sort of looking at the titles, I see you've been studying wellness for a while, what other programs have you worked with?
There's things that some places have Schwartz rounds. You know what a Schwartz round is? Schwartz rounds are, you can implement it right into your emergency medicine grand rounds. And what you do is you take a really emotionally charged case and somebody presents it, and then everyone will talk about it. It's sort of like an M&M. What is said in the room stays in the room, and there's no finger pointing. That's part of the rules of it. And it was instituted by this gentleman, Mr. Schwartz. I think his first name was Arthur Andrew or something like that, back in the 70s, and he was dying. He was given a stage 4 terminal illness, and he said, and no one spoke to him, and he had a lot of moral distress over his situation. He said, well, we've got to teach medical students how to do this, so he gave a lot of money to one of the hospitals, I think it was in New York, and they started these Schwartz rounds. So if you just Google Schwartz rounds, that's something that you can approach your PD with and say, hey, let's discuss this. Let's dissect this case just like you would an M&M. But it's done, and you have some facilitators so that it's not like a free-for-all, but you have somebody who's in charge of it and has done a little bit of thinking about it. The one thing I just want to add before we, because we have to go, our time is up, but I wonder if Veronica's attending could have said, even though she was hurried and it was change of shift, could have said 3 small words. Tell me more, Veronica, what you're thinking right there, instead of just cutting her off. And I wonder if that would have decreased her moral injury. You know, obviously you're going to do what the attending says, but at least there'd be a little communication there. So we should probably let you go since there's time. We hope you gave you a few tidbits, and we really appreciate you listening to us.
Thank you.
Thanks.